Welcome back to the deep dive. Today we're digging into a really complex area, rheumatic disorders, using Porth pathophysiology as our guide. We're looking at, well, over 100 different diseases here.
It's a massive topic, definitely. And, people hear arthritis and often think it's just one thing,
Yeah.
but the numbers are pretty staggering.
Yeah, like osteoarthritis, over 30 million people in the U.S. alone, and rheumatoid arthritis, another 1.5 million. It's the leading cause of disability.
Exactly. So our goal today, our real mission, is to differentiate these. It really comes down to the pathology, the underlying mechanism.
And the key distinction seems to be about inflammation, right? Where it comes from.
Precisely. Think of two main buckets. First, you've got your systemic rheumatic diseases, things like RA, lupus.
Yeah.
Here, inflammation is the primary issue. It's driven by an out-of-control immune response.
Okay, inflammation first.
Right. Then, bucket number two, localized conditions with osteoarthritis, OA being the big one. Here, the inflammation is actually secondary,
Secondary, meaning
meaning it's a reaction to something else. In OA, it's a reaction to the joint breaking down, the degenerative process. The inflammation follows the damage.
got it. That contrast is crucial. Okay, so that really sets our path for this deep dive, doesn't it? We'll hit the systemic autoimmune ones like RA and SLE.
Then the spondyloarthropathies.
Right, those seronegative ones. Then tackle the big one, OA and gout, that crystal problem.
And we should also touch on how these show up differently in kids and older adults. It's important context.
Perfect. Let's dive into those systemic aggressive ones first, starting with rheumatoid arthritis, RA. If you need a classic example of immune-mediated systemic inflammation, this is it.
Yeah, RA is the poster child.
Yeah.
And the pathogenesis, well, the exact trigger is often murky, but the mechanism, it's a full-blown inflammatory cascade.
There's a genetic link, isn't there? HLA-DRB1.
There is, yeah, a strong genetic susceptibility. The idea is that maybe some trigger, perhaps a bug, kicks off a T-cell response in someone who's susceptible, and the immune system just doesn't shut it down afterwards.
And right in the middle of that runaway train is the rheumatoid factor, or RF.
Right, and RF isn't just some passive marker you measure. It's an actual autoantibody.
Yeah.
Your own IgG antibody starts reacting with other IgG fragments.
So antibodies attacking antibodies.
Basically, yeah, they clump together, form these big immune complexes. And where do they end up? Deposited right in the joint lining, the synovium.
And that attracts trouble.
Big trouble. Neutrophils, macrophages, all the inflammatory cells rush in. It's like pouring fuel on a fire that's already burning inside the joint capsule.
Which brings us to the pannus. This sounds really destructive. Can you help us visualize what's happening there?
Okay, the pannuses. It's the real hallmark of RA's destruction. Imagine this thick, sort of velvety, abnormal layer of tissue. It's full of blood vessels and inflammatory cells.
And it grows from the synovium.
Exactly. It starts in that inflamed joint lining and then spreads almost like a carpet right over the articular cartilage. It literally smothers it.
Smothers it, cutting off nutrients.
Precisely. Cartilage needs that synovial fluid for life support. The pannus blocks that, starves it, and actively destroys it with enzymes.
And unchecked, that leads to fusion.
Yep, ankylosis. The joint basically erodes and then fuses solid. Before you get there, though, clinically, the onset is usually slow. Fatigue, maybe losing some weight, feeling generally unwell.
And the joint pain itself.
Typically symmetric and polyarticular. That means it hits the same joints on both sides of the body, like both wrists or knuckles on both hands, and it affects multiple joints. Hands, wrists, knees, feet are common targets.
Which explains those classic hand deformities we sometimes see.
Absolutely. The swan neck, where the middle finger joint hyperextends and the end joint flexes. Or the boutonniere, which is the opposite middle joint flexed and joint hyperextended. That's from the erosion and tendon damage.
Devastating functionally. It really highlights why the treatment approach has shifted, hasn't it? Towards hitting it hard and early.
Definitely. The sources emphasize aggressive early treatment, using DMARDs, disease-modifying drugs like methotrexate, and especially the newer biologics like the anti-TNF therapies. The goal is to shut down that inflammation before the pannus causes irreversible damage.
Okay, so RA gives us a picture of primary inflammation, mostly hitting the joints. But then there's Systemic Lupus Erythematosus, SLE. It uses similar weapons, autoantibodies, but goes after, well, pretty much everything. The great imitator.
SLE is, yeah, a different beast. The core issue here is extreme B-cell hyperreactivity. These B cells just churn out tons of autoantibodies, not just the general ANAs, but highly specific ones like anti-DNA, anti-Semitism, antiphospholipid antibodies.
These don't just stay local.
Nope. They form immune complexes that circulate throughout the bloodstream and deposit in tissues everywhere. Skin, kidneys, brain, heart, lungs. causing chronic inflammation and damage system-wide.
We know about triggers like UV light, certain drugs, but the hormonal link is really interesting too. Way more common in women.
It is. There's a theory that estrogens might somehow promote the disease, while androgens might be protective. It adds another layer of complexity.
But calling it the great imitator, that's because the symptoms can be so varied.
Exactly. Joint pain, arthralgias, arthritis, those are common, sure. But the really serious stuff, the life-threatening manifestations, happen in major organs.
What are the biggest worries with SLE?
Kidneys and the brain are top concerns. Glomerulonephritis, inflammation in the kidney filters is common. And certain types, like diffuse proliferative, can rapidly lead to kidney failure. You often need a biopsy to know how bad it is.
And the brain.
You can get vasculitis causing strokes, or specific antibodies attacking neurons, leading to seizures, psychosis, even subtle cognitive changes. Then there's skin, the classic butterfly rash, the malar rash across the cheeks and nose, and heart and lungs pericarditis is pretty common.
It really drives home why diagnosis needs that multi-criteria approach, using specific antibody tests like anti-DNA, and treatment has to be focused on saving organs.
Absolutely. It's about preventing irreversible damage. So using everything from NSAIDs for milder symptoms to antimalarials, corticosteroids for flares, and stronger immunosuppressants like belimumab for severe or refractory disease.
Okay, we've hit the big autoantibody-positive systemic diseases. Let's pivot now. Talk about the seronegative spondyloarthropathies, CPA. Seronegative tells us no rheumatoid factor.
Correct. That's the key distinction from RA. They lack RF. But what defines them functionally, pathologically, is where the inflammation hits hardest. The entheses.
Entheses, that's where tendons and ligaments attach to bone, right? Not the joint lining itself.
Exactly. It's that interface point. This whole group, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, shares this feature, plus a strong link to a specific genetic marker, HLA-B27.
Let's focus on ankylosing spondylitis sequoias. The name suggests fusion. What's happening pathologically along the spine?
It's typically a bottom-up process. Inflammation starts, often chronically, at the entheses and the sacroiliac joints where the spine meets the pelvis.
Okay.
Then it creeps up the vertebral column. The body tries to heal this chronic inflammation at the ligament attachments by forming new bone. Over time, this new bone bridges the gaps between vertebrae.
Literally fusing them together.
Literally. Eventually, you can get this rigid column. On an X-ray, it has that classic bamboo spine appearance, completely fused.
And the symptoms are quite different from RA too, especially the back pain.
Critically different. The lower back pain in AS characteristically worsens with rest or inactivity. It's often terrible in the morning, causing prolonged stiffness, but it improves with movement and exercise.
That's the opposite of mechanical back pain.
Exactly. Immobility makes it worse. Over time, this leads to postural changes, loss of the normal inward curve, the lordosis in the lower back, and eventually an increasing forward hunch, kyphosis, in the upper back.
So treatment must focus heavily on movement.
Absolutely. Physical therapy is key exercises. Swimming, maintaining good posture, even the right mattress matters. Keep that spine mobile for as long as possible.
Now, pharmacologically, you mentioned something interesting. DMARDs like methotrexate, which are staples in RA, often don't work well for the spinal symptoms in AS. Why is that?
It comes back to the site of inflammation. DARDs are generally better at targeting the synovial inflammation you see in RA. Since AS primarily involves the entheses, the tendon ligament bone junction traditional DMARDs often miss the mark for the axial or spinal disease.
But anti-TNF therapies do work.
Yes, anti-TNF alpha drugs have been revolutionary for axial AS. They target the underlying inflammatory cytokines, driving the enthesitis much more effectively. Sulfasalazine, a DARD, might help if there's peripheral joint involvement, but not usually for the spine itself.
And we should just briefly mention reactive arthritis falls in this group too.
Right. Sterile joint inflammation that follows an infection elsewhere, like the GU or GI tract, sometimes called Reiter syndrome, same idea seronegative, often involves enthesitis.
Okay, let's shift gears completely. Away from primary immune attacks towards the most common arthritis type globally, the biggest cause of disability, osteoarthritis, OA.
Yeah, OA is everywhere, and it's fundamentally different. It's not primarily an inflammatory disease. Our sources describe it really well as a disorder of the entire joint unit, characterized by breakdown and, crucially, failed repair of the articular cartilage.
So wear and tear is too simple.
It is. It's more like the joint's maintenance system gets overwhelmed. It's primarily degenerative. Any inflammation you see is usually secondary, a consequence of the tissue damage, and the body's attempts to clean it up.
Walk us through that degeneration. What happens to the cartilage?
Okay, so normally you have this smooth, glassy, articular cartilage capping the bone end.
Yeah.
In OA, it starts to fray, lose its smoothness, develop surface scratches. These deepen, and eventually the cartilage can erode completely away in spots,
Exposing the bone underneath.
exposing the subchondral bone. And that bone reacts. It gets thicker, denser, and polished from rubbing against the opposing bone surface. That shiny, hard appearance is called eburnation.
And those bone spurs we hear about?
All right, osteophytes. The body tries to stabilize the damaged joint by growing extra bone around the edges. These spurs can restrict movement and cause pain.
And symptomatically, OA pain behaves differently too, right?
Completely the opposite of inflammatory arthritis like RA or AS. OA pain typically worsens with activity or use and gets better with rest. Makes sense, right? It's mechanical stress on a damaged joint.
Although in late stages, the pain can be there even at rest.
Yes, unfortunately. When you examine the joint, you might feel or hear crepitus, that grinding or cracking sound with movement. And the joint often feels enlarged and hard because of those bony osteophytes, unlike the softer, boggy swelling you might feel in RA.
Okay, treatment. The source mentions acetaminophen often being preferred over NSAIDs long term. Why is that if there is some secondary inflammation?
It's all about risk versus benefit, especially long term. OA is chronic. While NSAIDs are better anti-inflammatories, they carry risks. GI bleeds, kidney issues, cardiovascular problems, especially with chronic use. Since the inflammation in OA is secondary, the thinking is often to manage the pain first with something safer systemically, like acetaminophen.
But if the pain and inflammation are bad,
Then you might use NSAIDs, maybe topically or for short periods, or you go directly into the joint with injections. Corticosteroids can calm down a flare-up. And there's viscosupplementation, injecting hyaluronic acid derivatives to try and improve the joint fluid's lubricating properties.
but the foundation is always non-drug measures.
Absolutely.
Okay.
Reducing stress on the joint is paramount. Weight loss if needed, especially for OA. Using aids like canes or walkers.
Okay.
Physical therapy to strengthen supporting muscles.
Right, fourth category, crystal-induced arthropathies. Let's talk gout.
Gout. This one's metabolic. It stems from hyperuricemia, too much uric acid in the blood. Generally, we're talking levels over 7 milligrams per deciliter in men, slightly lower threshold for women.
And uric acid comes from purines.
Exactly. It's the end product when your body breaks down purines, which are found in certain foods and are also made by the body. If you produce too much uric acid, or more commonly, if your kidneys don't excrete enough of it, the levels rise.
And then crystals form. But why often the big toe? That classic podagra.
It's about chemistry and physics, really. Monosodium urate crystals are less soluble in the synovial fluid of joints than they are in blood plasma. And crucially, their solubility decreases further at lower temperatures.
So peripheral joints are cooler.
Right. Places like the big toe, maybe ankles, fingers, they tend to be a bit cooler than the body core. So they're prime spots for these uric acid crystals to precipitate out of the fluid and deposit in the joint.
And when they deposit, boom.
Boom is right. Immune cells, especially neutrophils, see these sharp needle-like crystals as foreign invaders. They try to engulf them with phagocytosis, but in the process, they release inflammatory mediators and destructive enzymes. That causes the sudden, intense, excruciating inflammation of acute gout attack. Often wakes people up at night.
And if this goes on chronically, we see those lumps.
Yes, that's the development of tophi. These are large, hard accumulations of urate crystals that deposit in and around joints, in cartilage, tendons, even under the skin. They usually take years, maybe a decade or more, to form after the first acute attack if the hyperuricemia isn't managed.
Diagnosis is key here. Just having high uric acid isn't enough, is it?
Absolutely not. Plenty of people have asymptomatic hyperuricemia. The definitive diagnosis of gout requires actually seeing those characteristic monosodium urate crystals in fluid drawn from the affected joint, viewed under a polarized microscope.
And treatment is a two-pronged attack.
Exactly. First, you treat the acute flare-up. That's all about rapidly reducing the intense inflammation. High-dose NSAIDs are common, or colchicine, sometimes corticosteroids.
Okay, put out the fire.
Right. Then, second prong, long-term management of the hyperuricemia to prevent future attacks and tophi formation. This involves medications like allopurinol or febuxostat, which reduce the body's production of uric acid, or uricosuric drugs, which help the kidneys excrete more uric acid.
And lifestyle plays a big role, too.
Huge. Avoiding foods high in purines like organ meats, some seafood, excessive red meat, limiting alcohol, especially beer, staying hydrated, managing weight. These are all critical parts of long-term control.
Okay, let's wrap up by touching on rheumatic diseases in specific groups, starting with children.
Right. The main one here is juvenile idiopathic arthritis, or JIA. It's not just one disease, but a group. Key subtypes include systemic JIA, which comes with high fevers, rash, and potentially organ involvement.
And the oligoarticular type.
Oligoarticular JIA affects 4 or fewer joints, often larger ones like knees. A really important thing to watch for with this type is uveitis inflammation inside the eye, which can be asymptomatic but lead to vision loss if not caught and treated. Regular eye exams are crucial.
Kids can get lupus too.
They can, yes. Pediatric SLE often presents similarly to adults, but sometimes kidney involvement is even more common and potentially more severe right from the start.
And juvenile dermatomyositis.
JDMS, a rare but serious condition affecting muscles and skin. Kids get specific rashes like over the knuckles and eyelids and muscle weakness. What's particularly notable in JDMS compared to the adult form is often a more widespread vasculitis, inflammation of blood vessels.
Okay, now flipping to the other end of the spectrum. Older adults. Arthritis is their #1 complaint, right? Threatens independence.
Massively. But diagnosing new inflammatory arthritis in older adults can be tricky. Why? Because comorbidities are common, and also older individuals often have low levels of autoantibodies like RF or ANA, even without having a specific rheumatic disease.
So more false positives on those tests.
Exactly. It muddies the diagnostic waters. But there's one condition we really need to highlight that predominantly affects older adults, usually over 60. Polymyalgia Rheumatica, PMR.
PMR. What does that look like clinically?
It's typically an abrupt onset. Severe aching and stiffness, primarily in the shoulder girdle and the pelvic girdle, so shoulders, neck, hips, thighs, often symmetrical. Morning stiffness can be profound, lasting for hours.
And there's a diagnostic clue related to treatment.
A very important one. PMR often shows a dramatic clinical response to low-dose prednisone. Like, within 24-48 hours, the patient feels vastly better. This rapid, significant improvement is almost diagnostic in itself.
But there's a dangerous condition linked to PMR.
Yes, and this is critical. PMR has a strong association with giant cell arteritis, or GCA, also known as temporal arteritis.
Yeah.
This is an inflammation of large arteries, particularly branches of the carotid artery, like the temporal artery.
That's a big danger there.
Blindness. GCA can affect the artery supplying the eye, and if it's not recognized and treated urgently with high-dose steroids, it can cause sudden, irreversible vision loss. So, any symptoms suggesting GCA in someone with PMR, new headache, scalp tenderness, jaw claudication, visual changes, that's a medical emergency.
Wow. That's a crucial connection. Okay, what a tour. Let's try to synthesize this. We've really drawn lines between the primary autoimmune systemic disorders like RA and SLE,
Driven by that primary inflammation.
contrasted with the localized degenerative syndrome of OA, where inflammation is secondary,
Right, breakdown first, inflammation second.
and the metabolic crystal disease of gout.
Triggered by those urate crystals.
And we also carved out the spondyloarthropathies, like AS, with their unique target, the entheses.
That tendon-bone junction, yeah. You know, if you step back and look at the bigger picture here, it's interesting. So many of these chronic conditions aren't just defined by the initial problem, the broken cartilage in OA, maybe the initial immune trigger in OA. A huge part of the actual pathology, the damage we see, comes from the body's own attempt to respond or repair.
How so?
Well, think about it. The destructive pannus in OA is an over-the-top immune reaction. The Tokay in gout form because the body tries and fails to clear crystals effectively. Even the bone spurs in OA are arguably an excessive remodeling response to joint instability.
So the response itself causes more problems.
Often, yes. It really makes you wonder, doesn't it? How much of what we treat as the disease is actually the consequence of the body's own, sometimes harmful, reaction trying and failing to restore balance? Something to think about.
That's a fantastic point to end on. Always question the mechanism behind the manifestation. Thank you for joining us for this deep dive into musculoskeletal function disorders. We hope this helps clarify these complex concepts. A warm thank you from the Last Minute Lecture team for tuning in.